Yes, sir. Yes, sir. Definitely, sir.
People will start now. Start. 1 minute. 1 hour disturb. Okay. I'm in a hospital. She came and they disturbed me. Okay. Good evening. Welcome to this peculiar case in the renal transplant, 28th edition of our show. It is going uninterrupted, and today we have two different presentations, and we have never had such kind of presentation in the past. It's going to be very interesting, and I'm looking forward to learning more and more here today. And we have two speakers, one from my place, my contemporary, Dr. Raj. He's a product of Stanley Medical College, Chennai, and he's been there more than a decade. And he is the man, is a very keen observer in every case, and a very good clinician and a complete physician in my I admire him a lot. And he never, he just get down to the brass tacks and try to unlearn everything from each case is given to him. He never take it lightly. Such kind of a great clinician I have with me here right now. I'm happy to be his contemporary in my place. And he's going to present renal transplant marrow dysfunction. The another speaker is the Gopati Raj, is a resident right now in CMC Vellore. He will be ably guided by his assistant professor Jitu Joseph Epan, and as soon as his presentation over, I think he will take over the thread and he will have more discussions about the case. And Gopati Raj is from our Trichy Medical College. He has done a UG here and subsequently Annamalai. Then now he's undergoing residency in CMC Vellore. And we have two very established and a very great panelist with us, and Sundar sir. And to say, we can say a lot about him. Even at this age, he never rests on his laurels, and still he is working like a full-time now resident. And he's a great educator. His name is spoken everywhere around the globe because his progenies are everywhere, and he has produced so many young graduates and as well as a good nephrologists across the world. And now he's in Astra Institute of Renal Transplant, Bangalore. He's an astute physician. In my opinion, when I traveled him a lot along with him in many places, and he's a good theologian. He knows much about our Indian culture, and he will teach a lot of life philosophies when you travel with him. Such kind of a great man, I could say. And sir is a founding member of ISOT as well as PDSI. And sir, good evening, sir. Welcome to this show. I think you are for the third time here in this play as a panelist. And now next we have Dr. Dipankar Baunik, and he's right now he's in Dharamsala, Himachal Pradesh, which is a hill area. It's surrounded by cedar forest, and it's a homeland of Dalai Lama. He's right now attending a camp for the Tibetan refugees, and just we heard from him right now. And he's a professor of nephrology at All India Institute of Medical College. He's a premium product of he's a premium nephrologist right there. Right, he's originally from Assam soil, and we are happy to have you here, sir. And I think your insights will be a great education for everyone assembled here. And without much ado, I'm jumping into the show right now. First presentation is by Dr. Gopati Raj. He's going to present persisting hyperparathyroidism after transplant. Over to you, Gopati Raj.
Thank you, sir. Shall I share the screen, sir?
Yeah, please. You are visible.
Good evening to the respective moderators.
Everyone to mute the audio so that we can listen presenter's voice clearly. Please mute all your noise should not interfere the presenter. Thank you.
Okay. Thank you, sir. Good evening to the respective moderators, and good evening to everyone. Today I am going to discuss about an interesting case of persistent hyperparathyroidism post-renal transplant. Short history: a 48 years old gentleman diagnosed to have a renal dysfunction on evaluation for bilateral expelling in September 2014 with serum creatinine 7.9 milligram per deciliter. He is a known case of systemic hypertension since 2013. He is not a known diabetic. No history of UTI or native medications intake in the past. Patient native kidney disease was unknown. Both kidneys were echogenic with loss CMD. Patient was started on maintenance hemodialysis since October 2014 with HD access left RCF. Patient then came to CMC for registration under disease donor renal transplantation program. On disease donor workup, he was found to have secondary hyperparathyroidism with serum PTH of 434 picogram per ml on December 2014. That time his calcium was 7.0 milligram per deciliter and phosphorus was 8.6 milligram per deciliter. He was managed with phosphate binders, active vitamin D, and calcium mimetics during the pre-transplant period, depending on his lab parameters. So these are all the calcium, phosphorus, and PTH values of the patient since his visit from the CMC, December 2014, to the subsequent days till August 2022. The PTH levels were on the higher range, but the patient never had a severe hyperparathyroidism feature like bone pain, bone fracture, or EPO-resistant anemia, intractable pruritus, and all. And patient was also on the top of the disease donor transplant program list. So we wanted to manage him we wanted to continue the medical management at that time. So patient underwent a disease donor renal transplantation on 13th October 2022. Donor details: 47-year-old male. HLA match of 1/12. CDC flow was negative. Single antigen bead was negative. Induction was graflon and maintenance spread packet MPA. Immediate post-transplant period, he had a slow graft function and renal biopsy showed diffuse acute liver injury with no evidence of rejection. He also had one episode of UTI after 6-month post-transplant period, and which was managed with IV antibiotics for 14 days and then resolved. In the post-transplant follow-up, November 2022, patient calcium was 10.9 and phosphorus was 2.1 and PTH was 260. PTH was a little high that time, but PTH was in decreasing trend. So our plan is to wait and watch. On the next follow-up in February 2023, the calcium was 11.8 and phosphorus was 2.3 and PTH was 273 and vitamin D levels were adequate. So we are started him on medical management with cinacalcet 30 mg once daily. On the further follow-up in April 2023, the calcium was 10.8, was still high, and phosphorus was 2.1, and PTH was still high. It was 205 picogram per ml. So we diagnosed him as PTH-dependent hypercalcemia and persistent hyperparathyroidism post-transplant. So we wanted to proceed the evaluation for the PTH-dependent hypercalcemia. So first we have done a PTH scintigraphy that demonstrated the bilateral inferior parathyroid adenoma, and this is also the another image that is showing that yellow enlightening spot that was bilateral inferior parathyroid adenoma, and the ultrasound parathyroid which shows a homogeneously hypoechoic lesion along the inferior pole of bilateral lobes of thyroid gland. And DEXA BMD assessment was done, which showed a severe osteoporosis with T-score of -4.2 in spine and T-score of -3.0 in female male. And during the workup of the above, patient one day presented the gross hematuria. So we planned for an ultrasound abdomen. In that, the non-obstructing calculus noted in the interpole region of the graft kidney measuring 5 mm. So we have done an X-ray KUB also. That also showed a calculi in the graft kidney. And we have proceeded for the CT KUB, and which showed a 14 mm calyceal calculus seen at the midpole of the graft kidney. So our final diagnosis was persistent post-transplant hyperparathyroidism with bilateral inferior parathyroid adenoma and severe osteoporosis and graft kidney calculi. So we have discussed with our urology team, and they have planned for a right attempted RIRS proceeding DJ stenting. Followed by that, he received 3 sessions of ESWL treatment. And we have discussed with endocrinology and endocrine surgery, and they have advised for the subtotal parathyroidectomy for the bilateral inferior parathyroid adenoma in the view of tertiary hyperparathyroidism. So bilateral neck exploration, 3.5 gland excision done on 25th July 2023. The intra findings were enlarged 4 parathyroid glands, the right superior parathyroid gland of weight 70 milligram, and right inferior parathyroid gland of size of weight 400 milligram, and left inferior parathyroid gland of weight 1 gram. The biopsy report of the excised parathyroid gland showed the right and left inferior parathyroid gland consistent with the parathyroid adenoma, right superior and left superior off gland with no significant lesion. In the post-operative course, on day 3, he had a severe tingling and numbness with chest site with serum calcium of 6.7. So he was managed with IV calcium gluconate and calcitriol at that time. And then he got improved. On day 6, he was asymptomatic and discharged with calcium of 8.8 milligram per deciliter and phosphorus of 4.9 milligram per deciliter. On further follow-up in August 2023, the ultrasound kidney showed a few calculi up to 2 mm noted in the interpole region. The DJ stent was removed and urology has given a reassurance for the stone clearance. So this is the X-ray that compared the previous before the ESWL treatment and after the ESWL treatment and parathyroidectomy. And the next X-ray on August 2023, the stone is completely resolved. This is the post-transplant labs in which the calcium is in normal range and phosphorus is 2.3 and PTH last tested was 11. So I just want to, this is all about the case we managed. And I also want to discuss something about the post-transplant hyperparathyroidism. So regarding the prevalence of the post-transplant hyperparathyroidism, the high PTH level observed in the 80% of the patient throughout the first year. The complete resolution of the secondary hyperparathyroidism was observed only in 30% after 2 years and 57% after 3 years of post-transplant period. The main predictive factors of persistent hyperparathyroidism were dialysis vintage, that is long dialysis vintage, high pre-transplant PTH level of more than 300 picogram per ml, increase in the size of the parathyroid gland, or use of calcium imlifidase. Coming to the PTH level assessment, there is no consensus about the PTH cutoff level that identifies the persistent hyperparathyroidism or ideal time of PTH assessment after transplantation. Most nephrologists wait till 12 months for the normalization of the PTH level. If beyond 12 months the PTH level is more than 100 picogram per ml, we can diagnose them as persistent hyperparathyroidism. Parathyroid enlargement in secondary hyperparathyroidism is very important. It happens in 4 stages like diffuse hyperplasia, early nodularity, nodular hyperplasia, and single nodular gland. In that stage, nodular hyperplasia is associated with the reduced expression of both calcium sensing receptor and vitamin D receptor. And that is the stage, this is the pictorial depiction of parathyroid enlargement. So nodular hyperplastic lesion is a stage where the parathyroid gland goes for enlargement. In that, the volume greater than 500 cubic millimeter, a diameter more than 10 mm. That is where the patient failed to the medical treatment with the vitamin D receptor activator or cinacalcet. Parathyroid imaging, the first line investigations are ultrasound, which is highly specific, and PTH scintigraphy, which has high sensitivity. The second line investigations are CT and MRI. Usually, we have to go for the combination of the first line investigation, ultrasound, and PTH scintigraphy, which offers a better diagnosis and almost equal to the second line investigation, which we have done in our case. The relationship between the persistent hyperparathyroidism graft and patient outcome. Persistent hyperparathyroidism associated with hypercalcemia, hypophosphatemia, and nephrocalcinosis. An alert trial with a large cohort of 1,500 kidney transplant patients for the 7-year follow-up showed persistent hyperparathyroidism associated with increased all-cause mortality by 4% and renal allograft loss by 5%. And there is also a high remodeling rates with the cortical and trabecular bone loss and decreased bone strength. There is also graft dysfunction, which is probably secondary to the excessive vasoconstriction by IPTH and also tubular interstitial calcification. Comparing the cinacalcet versus post-transplant parathyroidectomy, a 12-month prospective multicenter RCT study compared subtotal parathyroidectomy versus cinacalcet in a kidney transplant patient with hypercalcemia and hyperparathyroidism. The primary outcome was normalization of calcium, which was achieved by 100% of patients in the parathyroidectomy group and only 2/3 of the patients in the cinacalcet group. Whereas the secondary outcome, that is the normalization of PTH, noted in 10 out of 15 patients in parathyroidectomy group and none in the cinacalcet group. And BMD improvement was also noted in the parathyroidectomy group alone. There are international guidelines. INDIGO 2020 suggests to measure serum PTH at the time of transplant evaluation and suggests not transplanting patients with severe hyperparathyroidism until they are adequately managed medically or surgically. But 2015 European Renal Best Practice on kidney donor and recipient evaluation recommend not refusing the cadaveric transplantation because of uncontrolled hyperparathyroidism in the recipient, which was followed in our case. And this is the important slide, the indications of pre-transplant parathyroidectomy. If patient is having severe hyperparathyroidism, we have to first start the medical management with vitamin D analogs, calcitriol, as well as phosphate binders and calcium mimetics. For at least 6 months, if the patient PTH level is persistently more than 800, especially along with the severe hyperparathyroidism features like bone pain, refractive pruritus, and EPO-resistant anemia, in that case, we have to plan for a parathyroid imaging, mainly ultrasound as well as PTH scintigraph. If the parathyroid gland enlargement, that is a volume more than 500 cubic millimeter or diameter more than 10 mm is present, we can plan for a pre-transplant parathyroidectomy also. So the take-home message is the calcium phosphorus PTH should be assessed at the time of transplant workup. Long dialysis vintage pre-transplant PTH more than 300 picogram per ml, parathyroid size more than 10 mm diameter, and use of calcium mimetics or major risk factor for predicting the persistent hyperparathyroidism. Parathyroidectomy normalizes the PTH as well as bone mineral density compared to the cinacalcet use. Pre-transplant parathyroidectomy can be considered in patients with severe disease, considering the graft outcomes and surgical related complications in the post-transplant period. And the PTH more than 800 picogram per ml after 6 months of medical therapy, including the cinacalcet, plus the parathyroid volume more than 500 cubic millimeter, a size more than 10 mm diameter, refer for parathyroidectomy irrespective of calcium and phosphorus level. Post-parathyroidectomy, hypocalcemia is mostly transient and needs the management with calcium and vitamin D supplementation. So actually, this kind of patient needs a multidisciplinary management. So we have got help from Department of Urology, Department of Endocrinology, and Department of Endocrine Surgery from CMC well known to manage this patient. I thank my head of the department, Dr. Vinay sir, and my professor, Santosh sir, for giving me this opportunity to present in this platform. And I also thank my moderator, Jeetu sir, for the guidance.
Thanks, Gopadiraj. Can you unshare the slide?
Yes, sir.
Yeah.
Well,
Yes, sir.
I joined late. I mean,
Sir, good evening, sir. Welcome. Yeah.
Is there a scope for, instead of open parathyroidectomy, installation of, chemical ablation of parathyroid? I remember seeing cases being tackled that way. What does he say? Did he mention anything about that?
No, nothing, sir. He said, if he said 4-stage hyperplasia, early nodular or nodular hyperplasia, then it becomes adenoma. It becomes autonomy of it mimics like a primary hyperparathyroidism. When cinacalcet doesn't work anymore, when the volume is more than 500 cubic millimeter and the diameter, horizontal diameter more than 10 millimeter in size, I think it's a indication for surgery. And he narrated very nicely, sir. And probably, I think,
as a interventional
fellow,
fellow, that caught my attention when I came across it somewhere. With injecting the sclerosant sort of thing into the parathyroid, and have you heard of it? I think,
sir. I mean, all the we don't have any experience. I think none of us don't have any experience. I think.
But see, in Manipal Hospital of Somsekhar, my colleague has been doing parathyroidectomy with radio-guided excision on the table with a gamma camera. Excellent research. He's one of the largest experience of parathyroidectomy published in our experience. I mean, this is 2006 paper. He and Dr. Balal have published the paper. I will send you that link. I'm just seeing that now. He uses radionuclide excision of parathyroid adenoma with a local gamma camera, and then he excises only the parathyroid adenoma, which is supposed to be a unique technique.
Yeah, thank you.
Thank you. Sir?
Yes, I think very well presented case and nicely discussed. Few comments and some clarifications. Yes, Dr. Gopadiraj, I just want to know a couple of things. Pre-transplant was a scan done of the system scan or some scanning of the parathyroids? Because I don't think you mentioned that. You mentioned post-transplant, but what was the condition pre-transplant? Can you just
The pre-transplant, we didn't do imaging, sir, actually.
you didn't do imaging. And your level that time was, I think, around 1,200, 300?
Yes, that time also PTH levels were quite high only.
They're very high. Yeah, they're very high.
Yes.
So the next question is that what were the maximum doses of calcitriol and or cinacalcet that you could give to this patient for medical management pre-transplant? You know, because that aspect I don't think you really mentioned.
Cinacalcet, we can give 60.
How much did you give? How much did you give? You know, this is what I was wondering.
We gave 30.
Cinacalcet?
Yes, sir.
You had given cinacalcet. So up till what dose could you give?
30 BD, 30 mg BD.
You gave 30 BD. Okay. And the calcitriol, how much could you give? You know, because the patient did have hyperphosphatemia, I can understand. But how much calcitriol you could give him?
0.5 microgram TDS they have given twice daily.
Okay.
Sir, if I could answer that question.
Yes. Yes. Yes.
Yeah. Hi, sir. So first was regarding the question regarding PTH imaging. Yes, definitely PTH imaging would have been helpful in the pre-transplant period. The only question was, would we have reacted any differently? Would we continue medical management for the same even after diagnosing a PTH adenoma, or would we have pushed this patient for a parathyroidectomy before transplant? Usually what we would follow is, even if we identify a PTH adenoma in the pre-transplant period, we would try and manage this patient medically with calcium mimetics and active vitamin D, provided the patient did not have bone fractures or renal stones or severe myopathy or intractable pleuritis. So yes, we have done PTH scintigraphy for some patients in whom we have suspected a tertiary hyperparathyroidism. But in the absence of all these features, we would still have probably managed this patient just with medical management alone. I'm sure there are other can make the opposite argument also, saying that
Yes.
all this you could have avoided in the post-transplant period. But what is usually noticed is after the renal transplant surgery, as Gopati mentioned, up to 50% of patients, their PTH levels can come back normal. And often you can get away by just managing them medically. So that is what we usually see. Even if they have persistent hyperparathyroidism in the post-transplant period, we are able to manage them medically. This patient was unique in the sense that he developed severe hypercalcemia and he developed stones, graft kidney stones, which is a very, I don't think it's a very common manifestation of a hyperparathyroidism. So that's why this patient was taken up for surgery. Just to add to what Dr. Gopati Raj already mentioned, hyperparathyroidism post-transplant can have two presentations. One is with hypophosphatemia, and the second is with hypercalcemia. Hypophosphatemia is what we commonly see in the post-transplant period. And usually in these patients who develop hypophosphatemia without hypercalcemia, we are able to manage them with vitamin D supplements and active vitamin D calcitriol as needed. The second group of patients are those who develop hypercalcemia. And even in the patients who develop hypercalcemia, many a time we are able to manage them with calcium mimetics. Cinacalcet would be the treatment. We wouldn't use the active vitamin D. But in this unique patient who developed renal stones, obviously we had to go for a surgical therapy.
Yeah, absolutely. Jitu, I fully agree with what you say. Even we follow more or less the same management, but then I think we do scanning as far most of these cases who have high parathyroids more than 1,000 and they are not responding to medical treatment. In one of recent cases, we have gone ahead with surgery pre-transplant, removal of 3.5 glands. So that is just one comment. He has mentioned the discussion very well. I think he's covered most of the things. Etelcalcetide is the other drug which has now been tried, and the advantage is that it has long half-life. and it's given intravenously post dialysis, so just to add to what he has said in the discussion. So etocal I'm not sure if it is FDA approved or not, but then yes, it is used in many centers because it has better compliance with lesser side effects and a long half-life. Sir, ethanol, I'll just mention, what I've heard, I've not used it, I have no personal experience, but then what I've heard in various conferences is that ethanol is effective initially, but the chances of recurrence, I am told, is probably a little high. It comes back probably unless you have done a transplant. So especially those who have long vintage of dialysis and have no prospects of transplant, ethanol is not a very good option, but probably it would recur. So then, of course, parathyroidectomy would remain the ultimate treatment. So
yeah, Dr. Sampath here. Dr. Baumai, can I just
yes.
interrupt?
Yes.
Yeah. See, we have published recently, a couple of years ago, on the Indian Journal of Transplantation about our experience in the post-renal transplant hyperparathyroidism. I don't know whether the postgraduate has gone through our paper. It shows that a significant number of people post-transplant have non-resolved hyperparathyroidism. Even though many of them are asymptomatic from the musculoskeletal point of view, we don't have data on how the graft function is impacted by the persistent hyperparathyroidism. So this is another issue that generally we don't monitor the PTH levels in our post-transplant people, and we are happy with the normal creatinine and we go ahead. But when you start looking at it, you will find that a significant number of them have two peaks. One peak happens immediately post-transplant, and after a few years, when again the graft dysfunction starts, after 3 or 4 years, again there is an increase in the parathermone. So whether it has got a prognostic significance in the chronic allograft nephropathy is also another issue we need to keep in our mind.
Sure. In fact, he did mention that I think almost 80% patients, if you really look for it, they would be having some sort of hyperparathyroidism. Yes, he mentioned 80%. But in some other studies, I mentioned about 50% after 1 year. So yes, we don't look at it, but then it is quite common. Yes.
There is another issue of hypophosphatemia due to the FGF23 also. It can again be persistent in the post-transplant period. And so these two things we have to keep in mind.
Yeah, but that's another thing we don't check. The FGF23 levels are very high in these patients. And this patient had a vintage of almost 8 years, I think. Dialysis vintage of about 8 years.
Sir, can I? This is Dr. Gauri Shankar. Regarding alcohol ablation, I have seen it in primary hyperparathyroidism patients. The main issue with alcohol ablation in most of PHPT patients where like a redo surgery chance and the anatomy is totally disturbed. So it will make the surgeon very difficult when there is a recurrence for the surgeons to reoperate on these cases. So probably if there is a severe hyperparathyroidism which is not responding to CSR agents and calcitriols, active vitamin D, then our surgeons used to do parathyroidectomy and then take up the patient. But then that should not unduly delay the transplant of the patient. That is one point. And another point is regarding the phosphatidulopathy and the acute tubulointerstitial injury, which these patients can have in case of persistent secondary hyperparathyroidism, which is a known entity which can be seen post-transplant in these patients.
Okay, good point.
Yeah, and just one comment regarding the imaging. I just wanted to reinforce that because often these glands are not picked up very well and they may be missed. They may be supernumerary glands. So nowadays this 4D CT is the other thing which has been mentioned, and there are papers on imaging by 4D CT so that you don't miss any gland lying, especially maybe in the thorax. and other places.
As a corollary to Baumix's comment regarding the localization of the tumor, it has been seen that the system-AB PET has got a bit low sensitivity and the false positive rates are high. So people go on to use choline PETs. So it has been said that the choline PET CT scan has got high sensitivity. Of late in our nuclear medicine units, they use choline PET, and the chance of localization of these tumors are high. And the chance of ectopic localization are also high when we are operating on cases of men and other things. So choline PET is another modality. When in doubt with system-AB PET, we can go for it.
It's very important, no, that we look for any ectopic glands. It's very important.
Jito, just a curiosity. Have you just looked up any literature that in the graft having a calculus in a tertiary?
Yeah,
that's very rare, right?
That's why we decided to present this case, because as far as
I think the last 22 years practice, I think this is the first presentation I could see that.
So that's why we decided to present this case, because even in our, I haven't done a detailed search, but in a limited search, I couldn't find any cases, case reports of renal calculi recurring in the graft. But it's mentioned in literature that, renal stones can happen, but I couldn't find a case.
Calculus. It's a very big calculus.
Yes.
Dr. Jitu sir, just out of curiosity, in the presentation, the first presentation, like that is a calculi in the graft. I'm seeing a stent over there also.
Yeah, I think he had in between he had a DJ stent which was inserted for some other reason. I think he had a UTI, or I think there was an unrelated procedure.
Okay.
I thought it's for he had
ESWL also.
ESWL.
ESWL also.
I think put for that.
I think they stented him prior to ESWL.
Yeah.
Then they did a ESWL, then subsequently got the stone.
That's the procedure.
That's okay. Thank you, sir.
Thank you, sir.
I think you've done a very good job, and we are going with some takeaway messages. And what he said was, anyone who has got more than 800 picogram per ml prior to transplant, and if in post-transplant at 12 months, if it is more than 100 picogram per ml, if it's not responding to cinacalcate or vitamin D, and typical primary like a hyperparathyroidism, like stones and bones, psychic moans, and this is all the typical presentation of hyperparathyroidism. I think this is the way to go. And he added one more point. As Gauri Shankar said, choline PET may be the better to, pickup rate will be higher, and ectopic glands also can be picked up early. And he said 500 cubic millimeter of the volume and 10 millimeter of horizontal length. I think is the indication for intervention, and probably surgical intervention. Now experts are available. I think it's easier than going for any complicated injection, everything. And it's people are around here. Yeah, we have subjected most of the pre-transplant patients for some other purpose. They just do it very easily, parathyroidectomy. So I think this is a lot of take-home messages have been imparted here. Thanks, Gopithiraj, and your team and your Professor Jitu. And we'll move on to the next presentation by Dr. Rajan. Raj?
Yes, sir.
You can share your slides now. You have 35 minutes. Please go slowly and give us more information.
Yeah, thank you, sir, for the introduction and giving me the opportunity to present in spite of the elite in presence of the elite audience. This is a renal transplant in a marrow dysfunction. This is like a meeting line in its den. So we have done a renal transplant in 2 patients with aplastic anemia. Is it rare? And what are the ill effects of doing renal transplant in such condition? This is a curiosity triggers once you transplant the patient with aplastic anemia. We have seen many articles regarding the post-transplant anemia, post-transplant aplastic anemia, but I hardly encountered articles stating that renal transplant in aplastic anemia patients. So as far as my search is concerned, I found only 1 case report of such scenario in the world. And that too is from Manipal Hospital, Bangalore, that was published as a letter to editors column in Kidney International about the patient of aplastic anemia who successfully underwent a renal transplant. Another case report about a patient of a liver transplant, that is a donor with aplastic anemia who has donated the graft to the recipient. Apart from it, from my knowledge, it was I haven't seen any case reports of aplastic anemia. So what is that? It is a bone marrow failure, that is a decreased production of one or more major hematopoietic lineages, which leads to diminished or absent hematopoietic precursors in the bone marrow and attendant cytopenias. We have heard about aplastic anemia. And this figure shows about the hematopoietic stem cell that delineates into the myeloid progenitor and lymphoid progenitor. And that will ultimately differentiate into plasma cell lineage. And and myeloid progenitors will mature into your neutrophils, eosinophils, and platelets and red blood cells. Right side is a figure. It's a picture of a aplastic bone marrow that you find that there is hardly any cells visible, and it's all replaced by the fat globules. So bone marrow syndromes, when we classify, there are three types. That is three things we can classify as aplastic anemia, PNH, paroxysmal nocturnal hemoglobinuria, and MDS, myelodysplastic syndrome. From aplastic anemia, it can be either constitutional and acquired. Constitutional, that is inherited bone marrow failure syndromes, we have know about that Fanconi syndrome, Diamond-Blackfan syndrome, and Schwann-Diamond syndrome, etc. And about the acquired thing, bone aplasia can occur out of autoimmune manifestations, that is idiopathic, or toxic irradiation or infections, and pure red cell aplasia and agranulocytosis. These are all the acute forms of aplastic anemia. So depending upon the cause, that is cytotoxic drugs can cause, radiation can cause, and one of the important things is the benzene, which is obsolete nowadays, but in China, it's proved to be one of the important work spot toxin. And it can directly cause a physical and chemical damage to the marrow. Many times it is reversible, and it's one of the good prognosis when you stop the agent. And another one is immune destruction. It can be destroyed by immune way, by seronegative in any causes like seronegative hepatitis or thymoma, right? I think. And constitutional genetic disorders like telomerase disease and short telomere syndromes, Fanconi syndromes, other germline mutation where you have a defective DNA repair defects, which can cause a destruction of the myeloid precursors, causing aplastic anemias. So the treatment-wise, it has been divided. That is supportive care, from supportive care to hematopoietic growth factors, or hematopoietic stem cell transplant, or immunosuppressive therapies. So this is left side is showing the normal bone marrow with a good cellularity, and right side you are showing the hardly visible marrow cellularity with a lot of fat globules accompanying it. So once you see the bone marrow, you have to look for the dysplasia. Very important to differentiate aplastic anemia from the myelodysplastic syndrome, because finding dysplasia, because MDS can mimic aplastic anemia, finding your dysplastic cells, either like Puger-Hood anomalies, like these are all the dysplastic varieties. If you find this, then we may be dealing with the myelodysplastic syndrome, where the prognosis is somewhat different from that of aplastic anemia. So once you look for the bone marrow, you have to look for these dysplastic changes to identify underlying dysplastic syndrome. So again, cytogenetic anomalies is very commonly associated with myelodysplastic syndromes. Many times the deletion 7q differentiate hypocellular MDS from aplastic anemia. So this has to be done in the workup of when you see the aplastic bone marrow picture. So prognosis of aplastic anemia depends upon the severity of the disease. Mostly it correlates with the absolute neutrophil count. It is classified as a non-severe, severe, and more severe based upon your neutrophil count, absolute neutrophil count. Whether non-severe is more than 500, severe is 200 to 500, and more severe is less than 200. Age of diagnosis and start of treatment. Younger the age and earlier the start the treatment will be the prognosis. Older the age and delay in treatment is portents of bad prognostic indicators. More than 40 years, aplastic anemia portents one of the decreased response to hematopoietic stem cells treatment. So another, again, cause of aplastic anemia is very important. Inherited bone marrow failure syndromes like Fanconi's, like it has a very poor prognostic things. And also some acquired things out of radiations, out of your drug, out of toxins may have a good prognosis. And presence of cytogenic abnormalities also portends a bad prognosis also. So peripherally, severity of aplastic anemia, if 2 or 3 peripheral blood count criteria fits in, that is ANC less than 500, platelet count less than 20,000, and reticulocyte count less than 60,000, we call it as a severe aplastic anemia. So these are all the treatment modalities available. Either you start with immunosuppressive therapy, with no response, you go for a bone marrow transplant. So the prognosis of aplastic anemia, you have a 60 to 70% will have a long survival rate with bone marrow transplant. With ATG, that is immunosuppressive therapy, we have around 60% response rate in 1 year. And addition of cyclosporin has a reported rate of 85% hematological remission rate. So it's not that bad disease to have in this era of innovations and scientific technology, where you can give a good cure to many patients with aplastic anemia. On the contrary, if you make a survival analysis with the dialysis and transplant, you find that the relative risk of death is very much lesser when compared to the patient put on dialysis. Also, the right side features of Kaplan-Meier curve also showed that patient on dialysis fare very poor when compared to the patients undergo transplants. So this all put into the slides are important because to compare between the prognosis of aplastic anemia and dialysis and transplant, whether to venture into it because it was a frightened area and avoided area, whether to do a transplant in aplastic anemia because of its disease behavior. So with short introduction, I come to my case. He's Mr. S. His age is 37 years, and he is an ASRD, and native kidney disease was not known. He underwent a live-related renal transplant elsewhere in August 2016, and mother was a donor. She was on steroid-free protocol, though the treatment summary was not available with me. So his discharge creatinine was 1.8 as far as his comment, and he had a progressive graft dysfunction. He said that the graft wasn't settled after that. He underwent mesh herniaplasty for interstitial hernia in 2020, and ultimately started on dialysis because of graft failure in 2021. The result of the biopsy was not known, and he could not able to recollect what was that in the biopsy. So, next 1 year after starting the dialysis, he was curious of doing transplant and all. So, routine evaluation done on November 2021 showed that there is a cytopenia. That is, hemoglobin is 5.8. Total count was 2,900. Neutrophil is around 65.3%, and platelet count was 1,43,000. It's on the low normal line. So pancytopenia was detected first time. So again, we checked as a vitamin B12 and folate levels, everything was normal. And without further delay, we went in for bone marrow aspiration and also trophine biopsy, which was done on 23/11/21. The marrow was hypocellular. The cellularity in the hypocellular area is only 15%. Is 15%, and less than 25% of cellularity, we call it as we can take it as neoplasia. And megakaryocytes is nil because the presence of megakaryocytes, lot of megakaryoblast will indicate that we are dealing with the myelodysplastic syndrome. It's typically absent in aplastic anemia. And erythroid and myeloid series, that is unremarkable. There is no increased reticulin fibers, no granuloma. There was no immature precursors. It's important to see there is no immature precursors. We did a chromosomal analysis. We did the cytogenetics. It was a 46XY. There is no any cytogenetics was essentially normal. It doesn't reveal any deletion or missense mutation in the chromosomes. This is a picture of the bone marrow we received that actually you find that the cellulite is markedly reduced and is accompanied by a lot of fat globules. So based upon the clinical findings and the bone marrow, we termed as a non-severe aplastic anemia because his ANC counts is more than 500. And his platelet count is also more than 1 lakh, and though the hemoglobin is less. So prognosis as far as non-severe aplastic anemia is good, because he is younger, less than 40. He has no cytogenetic anomalies. He has non-severe aplastic anemia, and there is no dysplasia or immature precursors. And he doesn't share any clinical findings suggestive of inherent bone marrow syndromes, like syndactyly, polydactyly, or any other organ anomaly he didn't have. So He was started on, because of his non-severe, he was on consultation with the hematologist. He was started on danazol and L-tromopac. This is a thrombopoietin mimetic agent. And soon after, he was started monitoring for his blood counts. So serially, we find that the hemoglobin started picking up every month individual, and total counts started rising, but it was consistently is rising. And polymass also 50%, that's absolute neutrophil count is absolutely okay. And platelet counts also showing a improved trend and stabilizing trend. So the patient was insisting upon renal transplant, and he was not doing well with the dialysis, and family members also insisting upon renal transplant. So with a lot of hesitations, and because we don't have any protocols or things in the past, as we don't have any other case reports, so we are hesitant to do a transplant. But because the patient insists many times, we find that patients are pushing us to our limits and getting the job done. So because of non-severe aplastic anemia, it has a good prognosis. There is a consistent improvement in blood counts. It was never dropping. He was not requiring any transfusions. He was not having any infections recurring to the neutropenia or any bleeding diathesis. These are all the points that may pushed us to do a renal transplant in this patient. He proceeded with renal transplant as patient family members are keen in renal transplant. This time the donor was his spouse. She is 29-year female, B positive. HLA, it was an haplomatch. Luckily, it was an haplomatch. DSA was negative, PRA was negative, and CDC cross-match is also negative. Pre-op counts just before transplant, his hemoglobin is 9.6. Total count was 4,400. Neutrophils is 60%, platelets 2.63 lakhs. So we did a transplant in 15/8/2022, 1 year back. Induction, we gave an ATLG because he was not that much affordable for ATG, but nowadays we are using ATLG as an induction agent. Immunosuppression, tacrolimus, MMF, and steroids. And left lap donor nephrectomy was done, single renal vessels. This time it is a left renal bed, and anastomosis is done with a left external iliac artery. So now the therapeutic dilemma when we plan for a transplant. What induction agent has to be used, whether ATG or basiliximab? So if you see the treatment of aplastic anemia as an immunosuppressive treatment, ATG is said to be one of the important immunosuppressive treatment agent for the treatment of aplastic anemia. So ATLG is quite similar to ATG, so we just go ahead with induction with ATG. Maintenance immunosuppression, we had a mind. So whether to use antimetabolites or not, whether to go with the tacrolimus MMF steroids or tacrolimus everolimus steroids. Is a second transplant. He had a very stable counts, and we have to take a risk of taking MMF because initially we were hesitant to give MMF any antimetabolites, whether it will dangerously reduces his blood counts and potence him to infections. So, but we took a risk and started with TAC, MMF, and steroids. So MMF has been shown to be a good outcome compared to that your mTOR inhibitor. So we started with this regimen. So prior to the surgery, danazol was stopped and L-tromopac was continued and surgery was done. It was uneventful. And at discharge, his hemoglobin is 9.6. Total count was 6,700 and platelet count is 2.63 lakhs and creatinine was 9.96. He came last week, that is 1 year post-transplant, and his hemoglobin is around 13.5 and total count is 7,200 and platelet count is 1.9 lakhs and serum creatinine is around 8.6. For the past 1 year, it found that his counts was never decreased and he's maintaining the normal blood counts and his platelet was stable and his creatinine was stable and L-tromopac is now stopped and the patient is now on TAC, MMF and steroids with no other important symptoms. Coming to the case 2, he's a 42-year-old male. He's a CKD diagnosed 2020, native kidney disease not known. HT was inducted in January 2020, started on transplant workup elsewhere. On routine evaluation, his hemoglobin was 8.3, total counts was 2,000, DLC was 50, polymerase was 50%, sorry for the typo, and platelet was 1.74. Here the total count and hemoglobin was reduced, platelet was a little low normal. So again, we just went ahead with the biopsy. Here, you find that in hypocellular marrow, not bad as before, with no evidence of dyspoiesis or atypical cells. Marrow hypocellularity may express only it was evolving aplasia. It is not a full-blown aplasia because you can find still a lot of cells compared to the previous picture. And there was a direct toxic injury was also suspected because he had a native medicine intake one or 2 years back. So cytogenetics, again, we did a cytogenetics. Cytogenetics is an important armamentarium in diagnosing aplastic anemia. Along with the bone marrow defined biopsy, we have to do a cytogenetics to look for the chromosomal addition deletions because to look for the underlying MDS, because hypocellular MDS also mimics aplastic anemia. So he was again, because of non-severe aplastic anemia, he was started on danazol, eltrombopag, and erythropoietin. So the progress of his blood counts is like it has around stabilized around 8.6, and total count. For this patient, even though his marrow is somewhat good compared to the previous patient, his total count was around 2,900 to 3,000, so low normal. And though the absolute neutrophil count was pretty good, and the platelet counts has never dropped below 1 lakh. So again, with the experience of the previous cases, we just proceeded with the renal transplant because of his stable absolute neutrophil count. Though his total count was around the low normal, we just proceeded because of a stable ANC for past 3 to 6 months, and no requirement of blood transfusion, absence of any infection and bleeding diathesis, normal cytogenetics. So we just proceeded with renal transplant. So donor was his paternal aunt. She's 67 years female. His HLA was 3/6 match. CDC cross match was negative. Screening PRA done because the HLA was done in a lab which showed only one digit actually, that's given a ABDR actually, ABDR. So screening PRA surprisingly came to be weak. Class 2 was weakly positive. So I did the PRA by SAB. Class 1 is 19% and class 2 is 0%. Maximum MFA is around 1,200. It's not that much high. But so we proceeded with renal transplant. So this time I had a doubt of whether to give an induction or not because his counts was not that much higher. So whether to go ahead with induction agents or not, we had a lot of thoughts in mind. And PRA being slightly positive for the class 1 antigens, but I took a risk of not giving an induction agent because of fear of infection. I go ahead with the routine immunosuppression with the TAC of steroids. He's the first transplant. So after that, this is the creatinine report actually. So at discharge, it is around 1.4, and his blood counts has been followed for another 1 year. Actually, he found that it is again improving. Hemoglobin has touched 15.3 at discharge at present day. Sorry. And the total count is around 7,400. Polymorph is 73.2%, and platelet count is around 2.01 lakhs. His discharge current was 1.4. Now it's also maintaining 1.4. His urine routine is normal, and blood pressure is around 120/80. So we don't have a suggestions. We don't have a suggestion on when to do a transplant in aplastic anemia, but we have found 2 favorable factors like non-severe aplastic anemia, consistent response following treatment for minimum 3 months, and normal cytogenetics as a favorable factors to proceed with transplant. Those with severe aplastic anemia requiring transfusions, infections, repeated infections, or bleeding diathesis are all unfavorable factors. Persistent platelet count less than 1 lakh, persistent neutropenia, even with the treatment, myelodysplasia in biopsy, abnormal cytogenetics, and inherited bone marrow failure symptoms without treatment. They're all the unfavorable factors for doing a renal transplant. So points what we have learned from these 2 cases, whether we are right in doing aplastic anemia, we have to wait and see whether what is the course of aplastic anemia, whether it has a recurrent, whether it goes for a recurrence or it evolves into myeloma. But after discussing with hematologists what looks like a more benign one, so we proceed with the transplant. But we have to keep in mind regularly checking in for the relapse or progression of aplastic anemia. So renal transplant can safely be done in non-severe aplastic anemia. Maintenance immunosuppression, what we find that in first cases, we give induction treatment with ATG. Second treatment I didn't give, though the counts were low. But his counts, for both the patients, the counts has improved dramatically after transplant. Even after transplant, before discharge, also this counts has normalized and it was increasing. So we find maintenance immunosuppression can safely maintain the remission of aplastic anemia. Antimetabolites, which was feared one before, can safely be used without any danger of fall in counts. Proper evaluation of aplastic anemia can safely include and exclude the patients for renal transplant. And one query is those who have in my mind, which I can't get the answer, was that even if a severe aplastic anemia who underwent a stem cell transplant, how long we can wait to for the patients to undergo renal transplant if I happen to have a CKD also? That I cannot answer the question. And thank you very much for your patient hearing. Thank you.
Raj, and it was an exemplary. We learned a lot, and just straight away ask the panelists to lead the show.
Yes.
Dr. Bhaumik, please lead the show.
Yeah. Okay, sir. I have a couple of queries. From Dr. Raj, he's made a wonderful presentation, but just a couple of queries. One is that we see these cases now and then, and few things I think which you may have done, but you have not mentioned. I would like to know is regarding the viral infections in this patient, because both CMV and parvo we have seen even pre-transplant. And in fact, the first patient had already undergone a transplant. So you may have checked the CMV and parvo status of this patient.
Yes, sir.
Yeah,
CME status will be routinely seeing, sir, for
yes.
all patients. That is, we see the antibodies.
No,
and
I'm
for this patient,
I'm not asking for the antibodies. 99% of Indians are anyway positive. So I would like to know if the patient was, did you look for any active CMV infection or parvo infection?
Definitely. Once we find that, I forgot to mention this case, once we find the neoplasia, we just check for the CME PCR.
Yeah, you must have done.
So parvovirus, I won't, because it is usually causes pure red cell. It's not, doesn't cause an aplastic anemia. So I didn't check for the parvo. I checked for CMV, and also I checked for HCV also, HCV RNA and hepatitis B also.
And other thing is that what were the IPTH and the iron status, iron load in this patient?
So iron load, I haven't checked quantitatively, but the bone marrow, there is no ring sideroblast. Actually, we look for the bone marrow. So iron overload state was ruled out because the bone marrow doesn't show anything like that. So I didn't check for that.
PTH?
So PTH level is around it's in the normal range. It's around 200 to 250. So we check around every month and 3 months, every 3 months once. Before
how much EPO were you using in these patients?
So he was maintaining around 4,000 units. Yes, yeah, sir. He was maintaining around 4,000 units weekly twice.
That's not
per second.
Okay.
Yeah, but he was maintaining actually. That's why we are doing.
Okay. And the second patient also similarly, CMV was negative and...
CME was negative, and I didn't check for again parvo because the picture is not suggestive of parvo, bone marrow picture. And serology, hepatic serology, hepatotropic virus serology is also negative. And again, there is no ring sideroblast, that is no iron overload in the bone marrow. So I didn't check for the iron status also.
And one last question, how much TAC levels you maintained and how much MMF dose you gave, because even that I don't think you mentioned. That would be interesting to know.
TAC is a regular TAC level, sir. Actually, second transplant, I used to maintain within 1 month, I used to maintain around 10. Actually, I used to maintain around 10. MMF, I used around 1,500. Usually, I use around 2 grams. Now, for these two patients, I put it around 1,500 and carefully look for the counts to whether it fall. It never felt. So I just maintain around 1,500 milligram of MMF. And 2-3 months after, I just reduced to 1 BD, that is 1,000 milligram.
Okay, fine. And how long you plan to continue the Eltromobag?
Eltromobag, I have stopped after 1 month, sir. Once the counts has picked up, so I stopped. Both patients I have stopped after 1 month. Danazol I have stopped previously before transplant itself. I stopped, and Eltromobag continued for 1 month, and I stopped for both patients 1 month.
So the cause of the aplastic anemia, is it all idiopathic, or do you have any specific cause in mind?
It looked like an idiopathy. Second patient had a history of native medicine treatments that might be the cause of his thing. But other than that, apart from our workup and cytogenetics, everything, so it looks like an idiopathic aplastic anemia that is evolving. And I don't find any other secondary reason for that also.
Okay, thank you, Raj. I think it was nice and learning from wonderful.
Rajaraj, excellent presentation. I think you mentioned about the publication from Manipal Hospital that was done by one of our DNB students, Purnima, one case using tacrolimus. My question is now, for leukemia pre-transplant, is there a role of using GM-CSF or something, increase the count and do
No,
the
sir.
transplant?
No,
or is
sir.
it
No.
contraindicated? Because you
GM-CSF, yeah, GM-CSF, G-CSF is not at all indicated nowadays for aplastic anemia, sir. So the indications for aplastic anemia is one is that life-threatening infections with the absolute neutrophil count is less than 500. Then it has a role. Otherwise, there is no role for GM-CSF. Even for from our transplant point of view, GM-CSF is absolutely is not indicated actually.
Because that is one thing which always everybody has a doubt on this point, you know.
Aplastic anemia respond very beautifully with L-thrombopac. The thrombopoietin mimetic, it has a very good role, and danazol is found to have a very good role. So studies have shown that L-thrombopac, when combined with cyclosporine, has given a remission rate around 80 to 85%. Those who are not going for either bone marrow transplant. So with that drug itself, it is the counts were improving. So I don't think so any other.
So basically, I think many of, I think the thing is, we might have been earlier days, I think 30, 40 years when we started transplant, we might have been seeing this, but we never did a bone marrow and investigated. Maybe inadvertently, we were transplanting aplastic anemia and they were doing well after transplant.
Yes.
That's my feeling, you know.
Would cyclosporine be a better choice than TAC in these cases? I mean, just out of
Yeah, sir, but I don't want to take a risk of taking TAC because it's a second transplant. So I just went ahead with the TAC. It's all a trial and error phenomenon, actually. So just gave the TAC, look for that. The response is good, so I don't want to switch over to cyclosporine.
Raj, just when I observed your presentation, the earlier cases, first case, you said there is no megakaryocytes, right? Second, in view of you said megakaryopoiesis. What does it mean actually?
Actually, sir, the second case is an evolving. That's why it's called as an evolving aplasia. So if there is a dysplastic megakaryocytes, a lot of dysplastic megakaryocytes, then we can portend as the patient is having a myelodysplastic syndrome. So initial aplastic anemia, you find here a small number of megakaryocytes cells. If the cells are more than the normal cell, then you can say that it's a myelodysplastic. So if the aplasia evolves, then your megakaryocytes will come down. Actually, it will be absent actually.
Just observe that point. And too many, Sakti, you raised a hand for...
Sir, it's a nice presentation, sir. Sir, I have a doubt, but I don't know if it's a correct doubt or not, but in both the cases you've mentioned it to be haplomatch. First case, it was haplomatch. Wife, even then it was haplomatch. Second case, it was, I think, maternal land, and it was haplomatch. So my question is, should we try to do a stem cell transplant from these donors and then proceed with renal transplantation so the graft tolerance long-term is better for these patients with aplastic anemia?
Oh, so this is
early aplastic phenomenon.
Even if it's aplastic anemia, I'm just asking, could it be an option?
So indication for stem cell transplant. One is the second patient, his age is somewhat higher. So as the age goes above 40 years, stem cell transplant has a lot of ill effects and the success rate is lesser. So both the patients are non-severe aplastic anemia. They responded with the non-severe aplastic anemia. The initial treatment choice, as is shown in the slide, it is only a immunosuppression, or initially it was L-thrombopac and danazol. If not responding, then go for immunosuppression. So if the patient having recurrent infections, absolute neutrophil count is falling and thrombocytes come, then you can plan for a bone marrow transplant. Bone marrow transplant also, haplomatch is not enough. It should be a identical donor. Actually, HLA should be identical. Otherwise, you will have a rejection rates which is very high with this haplomatch. Haplomatch donation are nowadays being done, but the rejection rates are very high, GVHD rates are very high, and complications are very high. So it is not a good idea to do a stem cell transplant initially for the patient of non-severe aplastic anemia.
Okay, thank you.
I lost the track. Somebody has raised a hand.
Gauri Shankar.
Sir, I would just like to make comments. Both of the cases were exemplarily presented. Both of the cases we were luckily they didn't have severe aplastic anemia. So if in case of severe aplastic anemia, the point about thyroid profiles and EBV would also take up in the panel, I suppose. And what we do for any case of severe aplastic anemia patients is to look for the gene sequences, exome sequences to look for marrow failure syndromes. Because if at all we are taking them up for a haploidentical donor, which we were talking about, then a clinical exome sequence of both the donor and the recipient is mandated in that point. And it has been said that even after immunosuppression, we don't know whether it is the patient's own immune cell which is coming up, or it is a recipient cell which is engrafted and it is coming up. So you can check that also by looking up at the chimerism of the cells which are being shown up for post stem cell transplant. That is also one aspect of post stem cell transplant. And regarding this thing, how much time period should we wait post transplant? I don't think, with the limited amount of knowledge about stem cell transplant, adult stem cell transplant program which we had, our hematologist used to wait for around a year period of stability. If in case of particular disease, say for example PGNMID, they don't find they find a clinical remission of the disease. Say for example, in case of aplastic anemia, counts are reasonably well with hemoglobin more than 10 and platelet more than a lakh, and TLC, which is non-leukopenic, which is in the non-leukopenic range. People generally tend to clear of the case for renal transplant. But this is having said with no certain evidence base behind this. And another one point is regarding the graft failure and the bone marrow failure syndrome. If the graft failure in the first patient, if the patient had transaminitis, one another possibility that can be kept is oxalosis, because oxalate crystals can also cause myelophthalmic form of anemia with aplasia. So that can also be a cause. So if in rare cases, if we find to have transaminitis also associated with aplasia and a renal failure, and if the cause of renal failure is CIN secondary to RST, then oxalosis should also be considered as one of the possibility.
You said myelophthisis, right? Myelophthisis, right?
Yes, sir.
Myelophthisis, if I am afraid, Gauri Shankar, myelophthisis will be a cellular bone marrow or is an aplastic bone marrow?
Any granulomatous or depositions which is causing, which is obstructing the growth and other lineage development, sir. So in that way, if it is
the myelofibrosis, right?
in extreme form of myelophthisis, you will go for myelofibrosis and aplasia. But even in MDS at a rare, at the extreme end, you will have aplasia. Even in PNH at the extreme end, you will have aplasia. So any case of proliferative marrow at the extreme point will go for fibrosis and secondary aplasia.
Fine. Another dry tap in a bone marrow is myelophthisis and myelofibrosis. So you made a right point, Gauri, and I think we will wind up if there is no questions. Raj, you did an amazing job. I think the two cases you should present. Somebody should follow your footsteps in taking up this kind of cases. And you made a right point that cytogenetics is very important. And you also mentioned a point about hypocellular MDS, for wherein you require cytogenetics to differentiate between hypocellular myelodysplastic as well as early. The right, Raj? Am I correct? And
yes, sir. Okay.
You made a right point about that. Especially 7q deletion, right? Which differentiates hypocellular. I think this is a lot of you've given a lot of take-home points, and you presented. You took a lot of things from Harrison. I think it looks like almost we revised Harrison the initial part of the presentation, and you went on well with till the completion. You made a very so many points you are just given today. I'm very happy that just it's happening right under my nose in my place, and you're doing a wonderful job. Thanks, Raj, and
thank you, sir.
And Gopati Raj, are you here? Right. Thank you for your presentation, and two panelists, Sundar sir and
thank you for calling us. Thank you for calling me.
Yes, sir.
I learned a lot. Thank you.
Yeah, sir. That's always there, sir. And Dipanjan sir, I think right from a faraway place you attended, and it's I think your contributions.
Thank you.
Sir, fine, sir. And I thank all the participants and and the company, the MCure, Thangapandi and Karthik. They've been tirelessly working last few years to making this program more and more useful. And I request many people come forward with complex cases so that everyone will get a benefit out of it. And with this, I wind up this program today. And I think we will have extended time, I think 35 days, because they come very early. Next, Raj will present. And we have all our presentations loaded in YouTube. The same name, Peculiar Cases of Renal Transplant, will come as a YouTube a dedicated website has been created for this. So already we have uploaded 3 sessions in the earlier, we had those sessions be included, and one by one we will upload into the program. We can just hit Peculiar Case of Renal Transplant. You can view all the all the previous programs in coming years. So good night, everyone, and we look forward to having another interesting session the next month. Thank you, sir.
Thank you, sir. Thank you.
Thank you.
Raj.
Thank you. Thank you, sir. Thank you, Bhumik, sir. Thank you, Sundar, sir.
Yeah, good, sir. Good night.
Good night, sir. Good night, sir. Good night, sir. Good night, sir.
Bye-bye. Raj, good night.
Thank you, sir.
Good night, sir. Good night, sir. Thank you all, sir.
Thank you, sir. Good night, sir.